Hello, hello, and welcome to this episode of RevUp Health Podcast. Today, we are going to be talking about cardiovascular disease. It is February, it is National Heart Month, and cardiovascular disease is the number one killer.
And Valentine's Day is this month too, so we gotta love it. But essentially, with heart disease, obviously it's the big number one killer of individuals. So it's way more than any of the cancers, all the cancers combined, essentially. So it's something that we typically have a lot of questions about, and quite frankly is one of the more complex topics to discuss. And there's a lot of controversy and a lot of ideas, but we'll hopefully try to give you a little more education, a little more insight about the details of everything.
So one of the things that typically your primary care doctor is going to test every year is your lipid panel.
Yeah. So lipid panels, there's a lot of variety there too, but some of it actually will boil down to, well, really what order it was placed, what's physically the order coming from your primary care or your healthcare provider to see what labs they're going to draw. But a typical panel is going to essentially, a lot of folks think about is, total cholesterol. Well, what is total cholesterol? Total cholesterol is made up of HDL, LDL, and VLDL.
And triglycerides.
Those are basically just different size particles, if you will, different size lipid particles. And that's kind of a good way to look at it. And sometimes we'll a little more into the detail, but the larger particles are better than the smaller particles, essentially.
Where you get the good cholesterol and the bad cholesterol, as we've been conditioned to hear.
Right.
And something to just talk about, we talk about this in a lot of other ways too, as far as your total weight isn't as much of a good picture as what makes up your weight. So body composition. And in that kind of sense, your total cholesterol is not always giving you the answer.
Good analogy. So it's not always about the big number on the scale as much as it is about the components that make up that number. And that same principle, like you say, same principle applies to our lipid panels. But, with LDL, the main drivers with this is LDL and HDL. LDL is essentially what's really known as the delivery particles. They're the ones that kind of deliver the cholesterol. You can think of delivering the cholesterol to the tissues. And HDL are kind of the ones that are transporting. They're the ones that are metabolically, kind of give us a metabolic insight to what is really going on. And those are the ones that really transport the cholesterol from the tissues back to the liver to get broken down. So that's somewhere the reason that we have HDL being the good cholesterol to get it out of the tissues, whereas LDL is the bad guy taking the cholesterol to the tissues.
But as we're talking about the good guys and the bad guys, I do want to back up just a minute because we need cholesterol.
Yes. Cholesterol is a very important part of our life and is a necessary component to help produce the vitamin D, to help us with our immune system, to also help us with hormone production, specifically, the testosterone and estrogen. So those are the ones that are really important. Triglyceride is also another picture of our metabolic health and is often kind of looked at as a metabolic marker also. And we utilize triglyceride to HDL ratio quite often to kind of give us an insight to what is really going on in our metabolic insulin resistance states and what our dietary actions kind of look like. So
when we look at that ratio, it's really great if your HDL and your triglycerides are as close to the same as possible, or your HDL cholesterol is higher than your triglycerides.
Yeah, we just try to keep that triglyceride number under your HDL. And obviously the way that we're going to raise our HDL level is more activity, exercise, movement, sustained activity, whether it be zone 2 or HIIT, cardiovascular activities will, even resistance training will help improve HDL ratios. But another thing that's kind of missing from the conversation is some of the other little particles that maybe don't get drawn, the other labs that don't get drawn in our routine lipid panels. Those would be ApoB. ApoB is kind of an estimate of how many truly atherogenic particles we have on our LDL cholesterol. So that measures the actual components of the LDL particles that can actually create the atherosclerotic or lead to the atherosclerotic plaques build up in the arteries. That's why some people may have an okay number on their LDL, but their ApoB number may be a little higher. So that's those particles. We really want to get that ApoB number to know where we're at, because that's really the true driver of our risk for atherosclerosis.
Because the other thing to remember also is that LDL cholesterol we get from good, healthy fats that we encourage people to eat. Olive oil, avocados, coconut, all of those things can increase LDL. So knowing the difference between LDL and ApoB is really helpful.
Right. Another number that's kind of one of those that's not often drawn, but usually only necessary to be drawn once, is something called Lp(a). And you can think of Lp(a) is basically, it's an ApoB with an extra sticky protein on it. Now, the importance of this Lp(a) is that 20% of the population will have elevated levels of Lp(a). Those individuals are more at risk for developing heart disease because of the sticky nature, if you will, of that ApoB. This is 6 times, I don't know how they measured it, but it's 6 times the atherogenic effect of typical LDL. So you can see how bad it is to have that. So you may have normal-ish levels of LDL, but if your Lp(a) is high, well, that still puts you at a higher risk because it's a lot more atherogenic.
And this is a genetic marker. So you probably only have to have this drawn once to know if you are predisposed to having a hard time with your cholesterol.
Yeah. And keep in mind, it's only 20% of the population. So, and a lot of folks may not have had that drawn. So, but that's just a part of our panels, our serum marker panels that we typically look into for these things.
We don't typically do an Lp(a) unless somebody has unless we have a need to look a little bit further.
Right. Or someone wants it. True. So what's the inflammatory piece? Now, we have the cholesterol particles, we have the LDL particles floating around, the Lp(a) particles floating around. But you need to have more than just that floating around
in order to create cardiovascular disease.
Cardiovascular disease. Yes. Clarify that. So it's more than just having the pie. You've got to eat the pie too. So with the situation that we have, there's chronic inflammatory processes that are occurring within your system. Those kind of what we call oxidize. In other words, those are the ones that can kind of rust the particles inside the endothelial lining of our arteries. That leads to the thickening and plaque buildup. So it's not just because you have LDLs, not just because you have the ApoBs floating, you have to have the other component of this to have that problem. So just taking a statin and not changing your lifestyle is not helping you. That is helping a little, but there's more to it than just that. It doesn't give you a free ticket, taking a statin.
So one of the main things that we look at from an inflammatory piece with cardiovascular is the hsCRP.
Yeah, C-reactive protein. So that's an inflammatory marker, which will be elevated in some individuals, but it's that chronic inflammatory process. It doesn't specifically tell us where the inflammation is coming from, but it does give us a hint that there is an inflammatory response going on in our system, and that can lead to reactions within the endothelial lining, as well as anywhere else for that matter. So,
and something to remember with, like any labs, one snapshot doesn't always give you the total story. And the C-reactive protein can be elevated for other reasons besides chronic inflammation. Running a marathon could increase your C-reactive protein. Having an infection could increase that.
Yeah.
So it's something that we watch And if we have someone that comes back with a really high C-reactive protein, we're just going to monitor that and how it trends.
Yeah. And find out, well, what did you do recently? So transient elevations are one thing, but chronic long-term elevations are the problem.
Yeah.
That is the issue. Your body will be able to adapt to the acute changes, but the long-term problem is what always sets up the stage. You're always sprinkling gas on the fire. So that's what we want to do, is reduce that. And, numbers will suggest anywhere from up to 3 on the C-reactive protein is normal, but we like to see C-reactive proteins under 1 from a general standpoint on somebody that doesn't have any ongoing inflammatory process that would cause that to be elevated. When we talk about endothelial damage is a driving factor also for this. These are basically the things that kind of set the stage for the oxidation and the damage to occur, which can build up to produce the plaque buildup in our arteries. First on the list is high blood pressure. High blood pressure is an increasing process where the blood pressure increases and creates kind of a stress shear damage, if you will, to the endothelial lining.
And then high blood sugar or diabetes is another one. And that is because it weakens the endothelial tissue over time.
Yeah. And then, of course, smoking. Smoking is another big problem because that introduces a lot of harmful substances, which can create that oxidation and damage to the lining, as well as toxins, various different types of toxins that we'll get exposed to.
Like we've talked, high cholesterol is also something that increases risk, but knowing what parts of that cholesterol is high and where you're at there is really, really key.
And then, of course, any inflammatory process which creates oxidative stress. There are reactive oxygen species, which can be, I'm not going to go into the detail, but these things create an inflammatory process also, and then subsequently can kind of reduce the production of what we call nitric oxide, which is our bodies then has our ability to have kind of a vascular vascular elasticity. That's the best way I can say it. So it allows our blood vessels to relax. And of course, any lifestyle factors, physical activity, just sedentary behavior is also a driving force for having problems. You're going to have lower HDLs, which are the good guys, if you will. But, obesity and poor diet can lead to, structural changes. But, this metabolic dysregulation is really something that's pretty significant as a driver to this cellular dysfunction and our disease progression.
So some other things that we look at when we're looking at someone's cardiovascular risk. The next thing on our list is a coronary artery calcium score. And this is an actual CT scan that is done that will show if you have plaque.
Yeah, super fast, super quick, literally just takes minutes and it's very inexpensive. In our situation, literally it's a $75 test, and that's out of pocket. A lot of insurances may not cover that. So that's the reason why it's something that we'll order from a self-pay standpoint frequently. But you like to see that calcium artery score close to 0 if you can. When it starts sneaking up, that's, when it gets into the kind of the 125 plus range, that's when you start having a little more significant calcium artery buildup to the arteries. So what do we do about these problems with our lipids? The options are quite variable, as you can understand. We talk about, lifestyle changes and being a big contributing part to help reduce our risk. But there's also statins. Statins are one of the main go-to pharmaceutical driven processes to help reduce those LDL cholesterols. Yes, the benefits are those do reduce LDL, and the right individual, it's important, but there are associated risks that do come with those. Muscle symptoms and muscle problems, whether it be painful muscles or just more the substance of the muscle that takes its hit, because they do affect the component of the muscle and in turn can create some generalized weakness. Sometimes that's one of the only things that a person may notice is like, well, I'm just not as strong as I used to be. Well, there's a lot of causes for that, but statins could be a contributing thing to that. You can also have other, with statins, You can also have some problems with your liver enzymes. Yes, it will also reduce HDL potentially for you too, as well as there's a slight diabetic risk associated with it, but as well as cognition sometimes can be an issue. And, I don't want to go into the studies and the details right now, but yes, can be certain types of cancers which can be a little higher risk category taking statins. So,
And there is a statin, and is it more types of statins, or is it, you were saying that there's one kind that,
yeah, just statins in general. I don't really want to go into too much detail. It's not that one statin is worse than another, but some people may not have the response with a statin in general that they need to help reduce their risk. So,
and then what is the other type of pharmaceutical?
yeah,
It is
the PCSK9 inhibitors.
okay.
So statins will help to reduce the production of LDL particles, whereas the PCSK9 inhibitors help reduce the LDL by absorbing it into the liver. So number one, we don't produce it. Number two, we absorb it. The disadvantages of the PCSK9 inhibitor is a little pricey. It's an injection every couple of weeks. So that is for someone that really cannot tolerate use of a statin. Statins are first line from pharmaceutical standpoint. And then you get into the whole situation that, well, when should I take a statin? There are a lot of schools of thought about this. There are some people that don't want to take a statin, don't want to take the medications. Maybe they can't take it because they can't tolerate it. But certainly you can, by knowing, what your calcium artery score is, that can give you a little more assurance that maybe I can do some things to reduce my lifestyle input into this equation and help me reduce my cardiovascular risk.
Yes. And I think that it is very important to remember that this is a very personal choice. And, looking at all of the information in the whole picture and deciding which way to go.
Right. Some people may have a genetic predisposition to the fact that they have to do something. You have a choice. You have a choice to put that cigarette down or get moving activity-wise. I mean, there's a lot of things that are out there. So it's just a personal choice.
Yeah. And I think the other thing to consider too is that a statin may be a bridge to get you from where you are to where you want to be.
Exactly.
And to be mindful about that. If you start on a statin, be thinking about how you've also changed your lifestyle. We've got some patients who have been on a statin for so long, they don't even know what their lipids were before they got started. So we don't know now what it would be without a statin. They may not even need it.
Right. And now that maybe they're getting their insulin resistance under control or controlling their pre-diabetic tendency, that may be enough to help reduce their risk significantly for them. So that is a driver of triglycerides. So you can see it kind of all plays in. It's a multi-spoked wheel, and all the spokes keep the wheel rolling. So it's all about trying to find the right combination of things that will help. Typically also for individuals, maybe they're on a statin and it's like, man, I'm having some trouble with muscle fatigue, or I'm having some trouble with just pain or discomfort or aches. Well, there's some studies and some research to suggest that ApoG, Geranil, ApoG, that can be something on the line that which can help improve our body's ability to make CoQ10. Individuals that are on statins have a reduced ability to make CoQ10. And so that is something that will help from a health standpoint to the cellular health and oxidation. So what do we do next? What would you do? So if you don't know what your lipids are, it's a good idea to get those drawn.
Yeah.
That's first line.
And that is something that is very common in any standard lab draw for your annual health. Those are the numbers that your insurance company wants to check and make sure that you've had drawn.
Right. And you have to understand too, we talk to patients and counsel patients about this a lot, but there's a difference between normal and being optimal. The triglyceride levels, it's not normal to have elevated triglyceride levels that are above your HDL, period. So to be more optimal, that needs to be kind of a 1-to-1 like we spoke about. So that's something to consider too. Getting the old answer of it's normal is not acceptable necessarily to an extent.
And I also have to say that an LDL that is a little bit over normal may not be all that bad.
Right. It's not a sentence. It's a marker. Everything that we do, everything we draw, all these labs are markers to help us take a snapshot to see where we're at and what do we need to do different about our lifestyle. So that's also something to consider. But I would suggest for people to consider having their healthcare provider maybe draw an ApoB or an Lp to see kind of what their risk factors are, because those are really true good indicators of your risk for developing heart disease, much more so than just the total cholesterol number in general. Consider getting a calcium artery score. That's also something to kind of tell you where you're at, what's happened in the previous decades that leading up to that day. So that's something that would give you an answer. And if nothing, gives you a baseline, if nothing else. Maybe getting a CRP, C-reactive protein also, to look for the drivers. What's inflammatory related for me? What has been going on? So,
and then to know that the lifestyle factors, there are so many that are in your purview to implement lifestyle strategies that can really change your cardiovascular risk.
Right.
Strength training, zone 2, sleep, that's a big one. Stress, avoid smoking, and minimize ultra-processed foods. All of those things can really help.
Yeah. Sleep is one of those things that we frequently overlook, and not just laying down for 7 or 8 hours and calling it good. You got to get good quality sleep. And, if you've got obstructive sleep apnea, or if your partner's got obstructive sleep apnea, you're not getting good sleep, and that's the way that your body repairs and heals itself. So it's just important to get that. So I guess hopefully we've given you a little bit of clarity on this. This is not the all inclusive, but it's certainly something that you can start to digest and understand. Well, what do I need to do? Well, where do I need to go from here? At least you've got a roadmap to start to try to reduce your risk burden and reduce the inflammatory processes that you have control over. And yes, you do have control over your LDLs and HDLs, totals and triglycerides. So it's certainly something you do have control over. And, lifestyle changes are a good place to start.
Absolutely. So I hope that this has shed a little bit of light, not really meant to be fear-inducing, but just to give you some more information and some things to think about.
Yeah. So reach out if you have any questions, but we hope you have a healthy day.